introduction. So I'm going to talk on monoamniotic twin pregnancies, which is a special form of monochorionic twins. Now, yeah, I have to switch it on, of course. So I'm going to talk a little bit about the frequent we see monoamniotic twins, their typical features, and then how we follow them up and manage their complications. And then I will also address some special scenarios. Now, this figure is probably familiar to you. So if a woman falls pregnant spontaneously, she has 1 in 250 chance of ending up with monozygotic twins. And the minority of monozygotic twins, there is a separate placenta for each baby. But we also know that in the majority, 65% of identical twins, there is just one placenta. They are monochorionic. And actually, most monochorionic twins, fortunately, there is a separate sac for each baby. But we know that in 5%, in 1 of 20 monochorionic twins, the babies share a single amniotic cavity, which makes that in about 1 in 7,500 pregnancies will involve a monoamniotic twin. So you can calculate for your own region how many monoamniotic twins you're expected to see. And actually what's interesting is that females form the overall majority of monoamniotic twins. 65 to 75% are females. And now the hypothesis for that is that, and that's my favorite hypothesis, is that you have to be strong and you have to be a female to survive this monoamniotic setting. But more likely it is related to a process called X inactivation, which is a process where every cell in a female embryo has to inactivate one of its X chromosomes, and that coincides with monozygotic cleavage. So probably that's why we see more females in monochorionic twins in general, because in singletons there are less females, but in monozygotic twins, and especially in monoamniotic, and more so in conjoined twins, we have this female predominance. Now, like Asma already touched, upon the topic is that we know that these monoamniotic twins have an even higher risk of in utero demise than diamniotic twins, and that's not only because of the cord entanglement, and 90% of monoamniotic twins have entangled cords, but it's the combination of these pressure on the umbilical cord because of the entanglement, and then the fact that most have very big anastomosis that connect between the two fetal circulations. So we know that compared to diamniotic pairs, monoamniotic pairs, the cords are much nearer to one another in the placenta, and also the nearer the cord insertion, the bigger the communications between the twins. And actually, it looks almost like a singleton placenta.
Just one thing, could you use your cursor for the live stream people, if that's okay, because they won't be able to see the...
Okay. So, sorry about that. So this placenta, it's like a singleton placenta. You could easily imagine that there is only one cord. But yeah, this is typical for monoamniotic twins, that they're very near to one another. They're very big communications, and they perfuse their placenta together. So the increased risk of in utero demise, it's the combination of pressure on the cord and then sudden acute intertwin transfusions. So, as I already mentioned, there's a higher risk of in utero demise. We see 15% of monoamniotic twins as compared to 5% in diamniotic settings, so 3 times as common risk of in utero demise. And also after 32 weeks, this risk persists. So still 1 in 25 monoamniotic twin pregnancies will have an in utero demise. Now, different to diamniotic twins, this in utero demise is not predictable, so it's sudden, it's unexpected. Whereas we know that in diamniotic twins, the most common cause of in utero demise is twin-twin transfusion syndrome, and that's something that we can see coming on ultrasound scan. And that's again explained by this unpredictable compression and intertwin transfusion. Because the good thing about monoamniotic twins is that we see less chronic transfusion imbalances like twin-twin transfusion syndrome, which is a chronic process, and also twin anemia polycythemia sequence. And the reason why we see it less commonly in a monoamniotic setting is because the cords are very near to one another. You have these big anastomosis, so if there is a transfusion imbalance, it's acute and massive, and usually both babies dies. And these two placentas, they are actually from diamniotic twins. This is a typical TTTS placenta, where you see that the big bidirectional artery-to-artery anastomosis, which is typically seen in monoamniotic twins, is missing. And then obviously in TAPS, where you hardly can see any anastomosis, you really have to look very carefully and do very detailed injection to pick up the anastomosis. And then another, and that's less well thing in monoamniotic pairs, is that you see more anomalies. And an anomaly unique to monoamniotic twins is obviously the conjoined twinning. TRAP, like Asma said, are more common also in a monoamniotic setting, because for TRAP you need the large artery-to-artery anastomosis, but since most cases occur, since we have more diamniotic twins, most TRAP cases are diagnosed in a diamniotic setting. But in 1 in 5 monoamniotic twins, there's a major anomaly in one of the twins, and it's usually only one twin that is affected. And the most prominent anomaly that we see, the most common anomaly, is cardiac anomalies. So because of these increased risks, and because of the increased risk especially for anomalies and difficulty in management, all monoamniotic twins should be referred to a fetal medicine center. Now for their diagnosis, it's a first trimester diagnosis, and it's very simple. You just see 2 fetuses within the same amniotic sac. So you have a single amnion that encircles both babies, and both babies move freely within this shared amniotic cavity. And importantly, because still many people make mistakes about that, you can only diagnose the amnionicity after 8 weeks of pregnancy. We often get referrals at 7 weeks, and patients are scared to death because they're diagnosed with monoamniotic twins. You cannot diagnose amnionicity before 8 weeks because you can't see the amnion, and also the number of yolk sacs is not reliable to determine amnionicity. And this again, when in a diamniotic setting, you have what I like to call the empty lambda sign, so the apposition of the 2 amniotic sacs in between the babies. And obviously, transvaginal scan may be helpful if you're uncertain whether there is a separating diamniotic septum or not. And then cord entanglement, it's an additional feature. It's not a requirement to make the diagnosis, but often already from the first trimester onwards, you can see the cord entanglement either by pulse wave Doppler or power Doppler or 3D Doppler. But the fact that you don't see the cord entanglement, and in fact 10% of monoamniotic twins do not have this cord entanglement, does not exclude your diagnosis. The diagnosis is just by a single amniotic membrane encircling both fetuses. And then, like I mentioned, the number of yolk sacs is not reliable. People used to use that prior to 8 weeks to determine whether it's a monoamniotic or a diamniotic twin. We know that 15% of diamniotic twins have only 1 yolk sac, whereas quite a number of monoamniotic twins have 2 yolk sacs. So it's not a reliable method to determine the amnionicity. On first trimester scan, what you can also usually see, and it's not so difficult in the first trimester, sometimes it's much harder later on, especially in a posterior placenta, is to look at the cord insertion sites. And what you will commonly see is that the cords are very near to one another, and you can also interrogate often the artery-to-artery anastomosis linking the 2 cords. In the first trimester, we also label our twins. Now, that's a problem in a monoamniotic setting because babies switch position all the time. So you should look for discordances. And sometimes you're lucky and one has a single umbilical artery. Obviously, in a cardiac twinning, it's very easy to label the twins, or when there's a discordance in size. But in monoamniotic twins, discordance in size is much less common than in a diamniotic setting. Now, screening for chromosomal abnormalities in a monoamniotic twin pregnancy, you can use the combined testing, but then you have to take the average of the nucleus, because we know, like in diamniotic monochorionic twins, in 1 in 10 of these pregnancies, one twin or both twins will have increased nucleus, so you always have to take the average of the nuclear translucency. But more and more, and I must say in Belgium we are very lucky because NIPT is reimbursed for all our patients. We use NIPT because obviously monoamniotic twins are monozygotic. And although there are no data on that in the literature, we know that theoretically it should at least be as accurate as in singletons, because you only have they result from the same zygote. So when you suspect a chromosomal abnormality, how do you diagnose them? What kind of tests do you use? Now we use chorionic villus sampling in monoamniotic setting when both babies have an anomaly, or mom is or the family is known with a genetic condition, or whether it's just for to relieve maternal anxiety. But we would always do an amniocentesis in the situation where one of the babies has an anomaly. Obviously, and I must say I've never been in that situation where one baby had a normal karyotype and the other baby had an abnormality. But at least theoretically, if you would then diagnose 2 different cell lines in your amniocentesis, you would diagnose mosaicism. And that is relevant because in these cases, if you were to do a CVS, you may miss the fact that actually one baby has a chromosomal abnormality. In these, if they exist, I've never seen them, but I'm sure it must happen that in a monoamniotic setting, one baby has, for instance, trisomy 18, and the other one is normal. To diagnose that situation, then I think you would almost have to resort to a skin biopsy to diagnose that one baby is normal and the other one is abnormal. First trimester is also an opportunity to look for abnormalities. Like I said, 1 in 5 monoamniotic twin pregnancies, you must find an anomaly most often in only one baby. And the first trimester scan is an ideal opportunity to diagnose anencephaly, midline defects, megacystis. And at least in singletons, we know that nearly half of these anomalies can already detected. And then the typical trap sequence of monochorionic twins and then conjoined twins are obviously also first trimester diagnosis. And we also take the opportunity in the first trimester to look at the heart. Like I said, 1/3 of all anomalies in monoamniotic twins are heart anomalies. And we know, especially with the improvement of the scanning machines, that you can pick up anomalies like tetralogy of Fallot with a right aortic arch. So, but you have to dedicate sufficient time, of course, to do your scan. So when we leave the first trimester and we move to 16 to 26 weeks, then we follow them like diamniotic twins. We continue to screen for anomalies because brain anomalies, heart anomalies are sometimes things you only pick up later on in pregnancy. And although it's much less common, we also look for signs of twin-twin transfusion syndrome, twin anemia, polycythemia sequence, and selective IGR. So the follow-up of monoamniotic twins is basically the same as in a diamniotic setting. So an ultrasound scan every 2 weeks to pick up these problems. Now, on major anomalies, like I said, it's very common in a monoamniotic setting. How do we manage it? Well, obviously, because both twins are in the same sac, and there's always this risk of intrauterine demise of one or usually both twins, we manage them differently than in a diamniotic setting. For instance, for an anomaly that we know the baby will die soon after birth, like in bilateral renal agenesis in a diamniotic setting, then we would prefer to be conservative and offer palliative care for the abnormal twin. But obviously in a monoamniotic setting, we would tend to offer a selective reduction just to reduce the risk of late unexpected intrauterine demise. Selective feticide, Asma has already highlighted it, in a monochorionic setting is always you have to block the intertwin circulation by coagulating the cord of the anomalous twin and prevent exsanguination of the healthy twin. Especially in a monoamniotic setting, you also have to cut the cord because otherwise you can have late demise, and actually it's quite high if you don't cut the cord. We know that in up to 40% of cases you can have later demise of the healthy twin, which is obviously very dramatic for patients who went through a selective reduction and then lose their healthy twin at around 30 weeks because of cord entanglement, and that happens in up to 40% of cases. These surgeries obviously cannot be done in the first trimester, and we have to wait for fusion of amnion and chorion, and we tend to do them around 18 to 20 weeks. So first we coagulate the cord with the bipolar forceps under ultrasound guidance, and then we transect the cord using laser in contact mode, and to release the cord and to prevent a later demise of the healthy twin. The survival rate of selective reduction in a monoamniotic setting are probably a little bit lower than in a diamniotic pair, probably because this surgery is technically much more complex to perform, and most importantly, you work in one gestational sac. So if there is later rupture of the membranes, it's always the healthy twin that will be at risk of miscarriage or very preterm births. And that's also why the gestational age at birth is also somewhat lower than in a diamniotic setting. And this is just to show that, we had to learn from our mistakes. This was such a case where there was later cord entanglement and late demise of the healthy twin. So I think everyone agrees that in a monoamniotic setting, you always have to cut the cord as well. And obviously, because these are complex choices and the outcome is, there's no guarantee of a good outcome, we always offer patients a termination of the entire pregnancy as well. For TTTS and TAPS, like I said, TTTS, we see it in 10% of diamniotic twins, only 5% of monoamniotics. TAPS is also 5% in diamniotic twins. It's very, very rare, probably less than 1% in a monoamniotic setting. But if it happens, obviously, we know that we can do laser surgery as in diamniotic pairs, but obviously the surgery is a little bit more complex because of the cords that are near to one another, and also the risk of ruptured membranes, like for cord coagulation, is increased because you're working in the sac, in a common sac. Now, my experience is that if they develop TTTS or TAPS, you can usually do laser because it means that they don't have these big anastomoses, and that's obviously one of the surgical restrictions. If you have huge anastomoses, like you can see in this placenta, these you cannot separate. I mean, you can try, but it's not going to happen, and you will lose both babies by separating these twins by laser surgery. But if they develop TTTS, usually it means that surgically you can also separate them. So we would, in first instance, always try to do laser for twin-twin transfusion syndrome in monoamniotic settings. But obviously, if there's an anomaly or a severe growth restriction, then you can also offer cord coagulation and cord transection. And you can offer palliative care, especially if you're near to term amnioreduction, or exchange transfusion and transfusion for TAPS near the term of pregnancy. Obviously, if it's early in pregnancy and there are complicated features, again, we discuss with parents always the option to terminate the entire pregnancy. And then finally, selective IGR or discordant growth. It's much less common than in diamniotic twins, and that's probably because in monoamniotic pairs, because the cords are near to one another, the placenta is usually equally shared. But my experience is that you usually also have a difference in size and thickness of the cord, and that the outcome is even worse than in a diamniotic twin pregnancy, because you're more likely to have cord entanglement because of the difference in cord sizes. And the options are usually, if it's a severe selective IGR with severely abnormal Dopplers, is I think the best option there in a monoamniotic setting is to offer selective reduction by cord coagulation and transection, or especially if early in pregnancy, we discuss a termination of the entire pregnancy. Then in the viable period, and obviously there's discussion when would you start increased surveillance. And usually in my hospital, and increased surveillance is usually done by non-stress testing and combined with biophysical profile scoring. In our hospital, we don't do any CTG monitoring before 28 weeks, because the thing is that it's very difficult to get good quality registrations, and also you would be very worried of having false positive results and causing the birth of two extremely preterm infants. So in our hospital, we start from 28 weeks onwards, although we do 2 weekly scans between 26 to 28 weeks. There's a whole discussion whether the patient should be hospitalized or can be managed as an outpatient. There has been, I think, in this month's issue from the White Journal, a paper that suggests that the risk of demise is higher when patients are managed as outpatients. Actually, was I think 15% risk of demise in patients managed as outpatients, whereas this was only 6% in patients monitored in the hospital. So that's a difference of 9%, and that would mean that you would need to admit 11 patients to prevent one demise in a monoamniotic setting. I don't think the place is so important. I think you should follow them very carefully from 26 to 28 weeks onward. But it doesn't necessarily has to be in hospital. And I think the decision is for the patient to make. We still admit most of our patients because traveling to the hospital is too far to come every day or every other day to the hospital. And patients are quite happy to have reached that time period in their pregnancy, and they feel very safe and relaxed in the hospital. But it depends on, obviously, if the patient has small children at home and lives near to the hospital, and obviously outpatient monitoring is feasible as well. And we give steroids once we start, when we make the decision, and it's usually together with the neonatologist and together with the parents that we decide when are we going to go for both babies and deliver both babies. And at that time point, we give a course of lung maturation, and we repeat it prior to the planned birth, which is always by cesarean section, because the cord of the second twin can be around the neck of the first baby. So we always deliver them by cesarean section between 32 to 33 weeks, which, although there are no randomized controlled trials, this seems to be the best period to deliver these babies. But it's important to realize that about a third will already have been delivered by 32 weeks, either because of spontaneous preterm labor or because of distress fetal distress of one of the twins. And that's actually in our series. I'm getting old, and I've been working almost 20 years in the twin business. And from the monoamniotics that I admitted, about 1 in 5, I need to deliver earlier than 32 weeks. The overall majority has reached 30 weeks, so I try to prevent delivery prior to 30 weeks, but in about 1 in 5, you will need to deliver because of repetitive decelerations. And that suggests that the cord entanglement, it's a subacute event that you can usually see coming by doing CTG monitoring. I don't monitor my patients 24 hours a day, but we do 3 long CTG traces a day in the patients that are admitted in our hospital. And I must say, and I touch wood, that I haven't lost any of my monoamniotic twins with this management so far. So actually, and that's my main message, because patients are always very worried when they get a diagnosis of monoamniotic twins. I always tell the patients that the survival rate is not that different from diamniotic twins. So actually, if you have a normal first trimester scan and you have excluded major anomalies, the survival rate is 85% from our series, as compared to 90% in our diamniotic twin pregnancies. So it's only that the way towards 2 healthy babies is a little bit more complicated, and it requires a little bit more stress management from the patient, in the sense that if there is demise, it's always, especially in the pre-variable period, it will be unpreventable. There's nothing you can do to prevent the losses before viability. And also the patient needs to be aware that she will have to have frequent monitoring from viability onward, and that delivery will always be by cesarean section around 32 to 33 weeks. But if we adhere to that management protocol, then the outcome for these babies is usually quite similar to our diamniotic pairs. 2 special issues in monoamniotic setting is, it's important to sample the umbilical artery next to the fetal bladder because of the cord entanglement. Otherwise, you don't know which baby you're sampling. And then the issue that you often see, what we call notching, it's obviously due to the cord compression and to the large artery-to-artery anastomosis. But in my opinion, I've never acted upon it, and it's not a sign of imminent demise or not a sign that you should get your cesarean section room ready. So we tend to ignore it. And then the iatrogenic monoamniotic twin pregnancies and what we call partial monoamniotic twin pregnancies. Now, iatrogenic monoamniotic twin pregnancies, that's mainly after laser surgery for twin-twin transfusion syndrome, and it's something to look out for. Every patient that had laser surgery, every scan we looked at to make sure that we can still see the intertwin membrane and that both babies are on a different side of the intertwin membrane, because not uncommonly you will have an iatrogenic septostomy, which then results in a monoamniotic twin pregnancy. Now, I must say that after laser surgery, we don't manage them like monoamniotic twins because they're not at risk of this sudden demise, because they don't have these big anastomoses. So these patients, if it's iatrogenic, I do not admit them from viability. I would just deliver them by cesarean section and not by vaginal birth at around 34 to 35 weeks. And then something to also to pay attention to, and actually we have now followed 600 monochorionic twins from the first trimester onwards. So in the diamniotic twin pairs, we know that the risk is about a 1 in 100 that you have diamniotic septum in the first trimester, but that at 16 or 20 weeks you just find out that actually both babies are at the same side of the septum, so that they're actually monoamniotic. And we call them partial monoamniotic twin pregnancies. So there's only a partial diamniotic septum. And obviously you can imagine as pregnancy progresses, then the babies, they tend to like to be together and they just end up in the same sac. So the message here is to check for the intertwin membrane each time you do a scan in your diamniotic monochorionic pregnancies. And these pregnancies, we tend to manage the same as natural monoamniotic twin pregnancies. So we do intensive surveillance, and we do an elective preterm birth at around 32, 33 weeks. And then finally, the conjoined twins. Obviously, conjoined twins, by definition, should be monoamniotic. And it's very rare. It's about 1 in 40,000 pregnancies. I only see like 4 cases a year. And most of these pregnancies are in this group. So 40% are joined at the level of the thorax and 30% at the level of the umbilicus. And this is the rarest form, where the babies are joined at the level of the head. It's obviously a first trimester diagnosis, and the outcome is unfortunately very poor. Most cases end up with in utero demise, and the ones that make it into the neonatal period, there's still a very high risk of early neonatal death. So overall, there's only about 5 to 25% survival, and actually these babies are in the best prognosis group. And I must say that I've never had a pregnancy continue for conjoined twinning. So most of our parents, especially since it's an early diagnosis, they choose not to continue with the pregnancy. So as a conclusion, it's rare monoamniotic twins, but they usually do well. Although, like I said, the road towards 2 healthy babies is a little bit more complex and uncertain. It's important to look for anomalies. In about 1 in 5 pairs, you will find an anomaly, usually only in 1 baby. And you can offer fetal therapy for twin-twin transfusion syndrome or discordant anomalies, but it's much more complex and demands more expertise, and the risk of rupture of the membranes is increased, and miscarriage and very preterm birth. And we plan intense follow-up from viability onwards, and viability is something that has to be discussed with the parents and the neonatologist, and we deliver them by cesarean section at around 32 weeks. The girls I tend to deliver at 32 weeks, and the boys, since they need a little bit more time, I tend to deliver at around 33 weeks. Thank you very much.
Great. I've been told that I have to, if you're going to talk, you have to have a microphone or to be here so that people actually on the live streaming can hear us. Yeah. Well, thank you very much. That was.
There's one on live stream. It says, what is the cause for vanishing twin? Do we have to manage twins with HX of vanishing twin differently?
With what, sorry? With
history of vanishing twin.
It's more for you, I think, no? I mean, there's no vanishing twin.
Oh, for me, okay, sorry.
In monoamniotic setting.
The questions here. So vanishing twin is actually quite relatively more common than what we think. It's just the fact that we don't really scan a lot of the pregnancies very early. And in fact, the studies that often in IVF pregnancies, where they tend to have a lot of early scans, they would say that a lot of the singleton pregnancies actually started as a twin, and then had a vanishing twin. Yeah, so it's actually more common than what we think. Vanishing pregnancies complicated by vanishing twin. The majority of them have excellent outcome, and therefore you really should be positive with this woman. Sometimes they might have a bit of vaginal spotting, but the majority of them, as I said, the pregnancy will be fine. But in the era of NIPT or cell-free DNA, you should be careful, because vanishing twin could be one of the causes of false positive result on the NIPT or the cell-free DNA. But the majority of the times, these pregnancies do very well. Does that answer the question?
Well, they're online, so hopefully. Yeah.
Can you send a smiley face on? Yeah. Okay, so we have a question here. Or comment. I think you have to have the microphone so that people on the live streaming can hear us.
Monique.
Lisbeth, beautiful lecture with beautiful pictures. Could you comment a little bit more on the CTG tracings, and especially because I think they have to be read differently from CTG tracings from singletons, and that you have to train your junior doctors on your ward to look for different things in a monoamniotic twin.
Thank you, Monique. My experience is that we only act on repetitive decelerations. That's and obviously you have to be more strict the earlier you are in pregnancy. So my threshold to deliver before 30 weeks is much higher than once I've reached the 30-week period. What my experience is that you often have prolonged periods of tachycardia in one twin. I don't know if you've noticed that, and I've never acted upon that. I think it's also probably so one baby goes a little bit, the baseline goes a little bit down, and the other one goes a little bit up, but the beat-to-beat variability remains excellent. I've never acted upon that, so the only reason to get labor ward ready and the cesarean section room ready is for decelerations, spontaneous decelerations. I don't know what your experience is.
My experience is the same, but sometimes that junior doctors accept decelerations because in between the CTG is quite good with accelerations. Especially when you are above 30 weeks, that you should act on that decelerations and not say, oh, the rest of the CTG is good.
No, definitely not. No, that decelerations is a hallmark to deliver, not because obviously, the tachycardia will also is also not normal according to the classification of the CTG, but then we just leave the CTG on a little bit longer, and then you see that they come down again. But it's more common in these monoamniotic twin pregnancies, these sustained periods of tachycardia in one baby, but as long as the beat-to-beat. No, it's decelerations that are important.
Okay, question. So you have to take the microphone.
Sorry.
That's okay.
Thank you for the lecture. My name is Pilar. I come from Spain. I would like to know, when do you start doing the CTG in the monoamniotic twins? When do you start exactly? 26 weeks?
No, that's what I said. So no, I don't do CTG tracings before 28 weeks.
Okay.
I do twice weekly ultrasound scans. So, but I think the CTG tracing is very difficult before 28 weeks, and I would be very worried to have a false positive and take out two babies in an extreme preterm period. But we discussed with the neonatologist all these issues. So the patients are also aware that there is a risk of demise. But I don't want patients to be too long in the hospital. So that's also why I don't admit at 26 weeks, but rather at 28 weeks. Just to make it still bearable.
And when you start to do it weekly, and you combine with the Doppler scanning as well, or?
So we do CTGs once 28 weeks. We do CTGs 3 times a day, and then we do ultrasound scan twice a week. But it's more for the growth and the biophysical profile. I don't think Dopplers are very informative in monoamniotic twins, so it just see their well-being and.
Okay, thank you. I do have another question, because I didn't understand very well, why do they have less incidence of transfusion syndrome? Because they don't share the placentas. The sharing is much better.
They have these large artery-to-artery anastomosis, so we know that it protects against twin-twin transfusion syndrome and TAPS. So if you have an imbalance, it's so massive that usually one or both babies die, rather than first go through the twin transfusion syndrome and the TAPS. It's just very sudden because of the big anastomosis. And we know that the artery-to-artery anastomosis, it's bidirectional, so it protects against twin transfusion syndrome and TAPS.
Thank you very much.
You're welcome.
Great. Any other questions? Yes, I know, but I'm asking for these people. Okay, so we have 3 questions so far from the live streaming, and welcome to the people on the live streaming. I know some of you are my friends, so really nice to spend the weekend with you, even if you're far away. So the one question from Anna Maria, how do you map twins in MCMA pregnancy, which actually is covered by Elizabeth in her talk. So obviously it is more tricky because they change, they move, but certainly you try to find any discordance. So one baby smaller than the other, for example, or one have single umbilical artery, like what you said.
But most of the time you can't label them.
Most of the time it is a bit tricky. But the parents understand it. I mean, look, there are limitations to what you can do, and as long as you're clear about it and document it, you're doing your best. The other question is from Lata, from Bull, who's also my friend. So do you have to do uterine artery Doppler routinely as a screening modality for all twins? Very good questions. No, I don't think you should. I don't think you need to, according to the guidelines. So certainly in the ISWA guidelines, we did not say that we should do it routinely. Certainly there will be some centers where we do uterine artery Doppler routinely, like for example at St. George's where I work. But that's not necessarily because it's evidence-based and the fact that you should do that or you will act on the abnormal result. So if you have a question that's in line with sort of ISWA guidelines, the answer is you don't have to do it routinely. Having said that, there are some studies where they reported on the performance of the uterine artery Doppler to screen for preeclampsia in twins, for example, and the performance is similar to singleton but less accurate. So it's not as good as in singleton pregnancies. The next question, hi Dr. Khalil, from which umbilical artery Doppler chart do you recommend for monochorionic diamniotic monitoring, 16 and 18 weeks? Do you use the PI or presence or absence of the end-diastolic flow? This is a really good question. And you raised 2 points. Number one is the fact that in twins, sometimes you will see or you come across absent end-diastolic flow in the umbilical artery at a very early gestational age, like 16 weeks. And then when you scan them again, it becomes positive. And that's been reported in the literature already by the Italian group. And therefore, I think we just have to be careful not to... So if the biometry is completely fine and amniotic fluid is completely fine, and one baby have absent end-diastolic flow in the umbilical artery, I don't think we should frighten the parents unnecessarily because there is a high chance that when you scan them later, it becomes positive. And therefore, you have to be aware of that. The second question, which is which chart? There are twin charts that have been published for umbilical artery and middle cerebral artery Doppler. Okay, in my practice, we actually still using the singleton charts. We're not really using them. That does not necessarily mean that's the right thing to do. But as I said, there are twin-specific charts for the Dopplers. We do use twin-specific charts for the biometry because they've been validated and we published on them and so on. But we are not using the Doppler charts for twins, but they exist. And I think they exist from about 20 weeks. I don't think the range is before 20 weeks. What do you use, Elizabeth?
Yeah, we use the singleton standards, but yeah, the Dopplers are not... I mean, we sort of classify them as present or absent. I don't think the PI prior to viability is very informative. I think more like present or absent or...
Yeah, reverse. I mean, certainly, yeah. So certainly I think if you think of what would be the importance of it, well, it would be mainly if you have TTDS for the classification, and the classification uses positive or absent reverse. Mm-hmm. For selective restriction, again, positive or absent. For the umbilical artery PI, perhaps for the discordance, maybe later in pregnancy, we publish on that. But certainly in early, 16, 18 weeks, we'll rely on the positive and negative, but really be careful. In the uncomplicated twin pregnancy, be careful. Do not act on the umbilical artery Doppler alone. Yeah, is that clear? Okay, perfect. Any other questions? Any more questions from the live streaming? I'm just scrolling down. No. Shall we maybe just discuss about the outpatient versus inpatient monitoring of monochorionic, monoamniotic twins? Hands up to who actually admit the monochorionic, monoamniotic twins. Okay, anybody in the UK admits these patients? Okay, because we don't.
Yeah, but I think if you live in a city like London, everything is I mean, the patient, it doesn't matter where she sleeps, if she sleeps in her own bed or if she sleeps in a hospital bed. It's what you do with the patient. And I think in London, it's quite easy to come every day.
We don't even bring them every day.
Yeah.
I'm not saying that this is the right.
Yeah.
I'm not saying, but we don't. I mean, anybody bring this patient every day to the hospital?
Yeah, we see them. We admit
yes,
them.
I mean, I don't, maybe you're right. I mean, I don't know.
I think, yeah, I mean, the whole literature points a little bit towards, I mean, the more detailed the surveillance. I'm not talking about in or out hospital, but the more carefully you follow them, I mean, you're definitely... I had one patient who went, she lived elsewhere, and she went elsewhere for follow-up, and they told her, oh, what's the problem? I mean, if I see you every week, that would be fine. So since she had small children, she just went every week, and she ended up with losing both babies, which is a little bit
sad.
Sad, yeah, especially after 30 weeks.
Okay.
What about telemetry?
Yeah, but who is going to look at these CTGs? And yeah, it depends on how far the patient has to travel to.
Does it exist?
In Hungary, we have it.
For twins?
But for single.
Yeah, for twins. Yeah.
Yeah, you have to talk in the microphone because...
If you see something, then you can still, be aware of it and then bring them to the hospital.
It's something we have to, we definitely can examine. I mean, it would be a big advantage, but I'm worried a little bit about putting on the CTG for 2 babies, and then also how quickly can you intervene if something...
Yeah. Okay, so just for the people now online streaming, I think the question was about what about telemetry in these pregnancies, and I'm very pro innovation, but I'm not aware of any telemetry for twins, but maybe there is. Maybe some people in the audience know that I'm not aware of.
In Hungary, it's a contraindication, but I think you can think about it in the future.
Yeah, interesting, something to look at. I think there was maybe one point or one at the back, I think. Okay, we are so behind, but I have a solution for it.
Just a quick question and a request. First is, thanks a lot, Dr. Asman, Dr. Elizabeth, for the nice talks this morning. The question is about CTG sinusoidal pattern. How good is sinusoidal pattern, absence of sinusoidal pattern in diagnosing anemia in or TAPS in twin? And the request is for multiple pregnancy with one sac rupture membrane, if you can shed some light on that. Thank you.
Okay.
So, yeah, it's for the twin anemia polycythemia sequence. I don't think we have information on that. I just had a patient that had TAPS, and we induced her because she already had 2 normal previous vaginal births, and the baby was anemic, but we didn't have the sinusoidal pattern. So I don't know there any data on that. I don't know, Monique in Leiden.
Okay, so there's no data on actually whether sinusoidal pattern when you see, which actually sort of correlate with anemia, fetal anemia. And TAPS, don't forget, TAPS, the majority of them will be early gestation, where you don't usually do CTG anyway, 20 weeks, 22 weeks, 28 weeks. We don't usually do CTG in twins at that gestation age. But also, I'm not sure that there's any data about how accurate. So do all fetuses near the end of the pregnancy who have anemia, do they all of them have sinusoidal trait? I don't think so. I suspect this is only in very severe cases and perhaps maybe acute anemia.
Acute fetal-maternal hemorrhage. I think MCA Dopplers are much more accurate to diagnose it.
And often these pregnancies have scans anyway, so you'll be able to detect that by the scan. The next question about rupture of membrane in one twin. Again, there's hardly any data, so and therefore the different centers will do different things. We tend to be conservative management, and we do have experience of women who, quickly go into labor, develop infection, go into labor. And we had also a member of staff who actually carried on, that happened at 16 weeks, carried on and delivered at 37 weeks. That's rare, that's not the usual. So, and therefore, I think there is an individual management. I think most people will manage as singletons to some extent. So in terms of monitoring for infection, counseling the woman, obviously if this baby becomes, so the rupture of membrane occurred very early, like 20 weeks, and then there's anhydramnios in this baby, you would counsel about the possibility of pulmonary hypoplasia, this baby might not survive, but you probably would do expectant management because of the other baby, yeah? Obviously, the option of selective feticide, you would discuss about the potential risks of the other baby. So, if you do it at 22 weeks and then she goes into preterm labor. Or actually, what about expectant management as long as there's no infection and this baby, high chance, will die anyway at birth? I mean, it sounds horrible, but that's an option, I guess, to reduce the risk to the other baby. Yeah?